and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shamagam. Part of what we all learn in medical school is the art of medicine, how to harness cutting-edge science and therapy and tailor that to the needs of the patients that we treat. We interpret these skills as bedside manner. Could the physician I'm seeing integrate the needs of the disease with the needs of the individual who has the disease, communicate the trade-offs, and the rationale for therapeutic options? In this age of technology, artificial intelligence is trying to mimic many of the skills we thought were unique to humans. Anyone with children knows that the favorite joke of asking Alexa to play dance music. And academics are worried about chatbots writing term papers. And I've even heard that AI has been used to generate radiology reports and songs in the style of Taylor Swift. And once you think a robot could do as good a job writing songs as Taylor Swift, you start to wonder, could robots replace the unreplaceable? Could they take over the role of a rheumatologist? The manuscript we're going to be discussing today is Machine Learning Applied to Patient-Reported Outcomes to Classify Physician-Derived Measures of Rheumatoid Arthritis Disease Activity, which was published in ACR Open Rheumatology. A link to the manuscript is in our show notes from today. And our guest is the first author, Dr. Jeffrey Curtis. Dr. Curtis is the Harbert Ball Endowed Professor in Rheumatology and Immunology at the University of Alabama at Birmingham. He has many accolades to his name, including being a prior winner of the Henry Kunkel Young Investigator Award and being a member of the American Society for Clinical Investigation. But the achievement he was most excited about on his Twitter feed is that he was lucky enough to have scored tickets to the upcoming Taylor Swift concerts. So, since he is an expert in both machine learning and Taylor Swift, I thought he was the perfect person to integrate all of this for us. Welcome to the show, Jeff.
Thank you. It's a delight to be here, and I appreciate the opportunity to visit with you and your audience.
Thank you. So you have a long history of working in patient-reported outcomes research, and you conceived of this particular study prior to the pandemic. I wonder whether you could share with us some of the background behind this manuscript. What prompted you to look at patient outcome measures as potential surrogates for clinical outcomes? And then in the context of the pandemic, why did that research become doubly important?
Those are great questions. And you're right. This process examining these important questions was indeed conceived before the pandemic, largely motivated by the opportunities that as physicians we have to interact using digital health tools, smartphone apps, or even passive sensor devices with our patients, not just the 5 or so times a year that we might see them in our rheumatology clinics, but the other 360 days of the year that they're not coming into the rheumatology clinic. And inasmuch as a smartphone app or other data about patients might be able to be gleaned in a continuous way, not just a few discrete times a year, this was the motivating factor for why looking at patient-reported outcomes might be surrogates for what we might learn from patients by examining them in the clinic and doing a typical physical exam. The second half of your question, in the context of the pandemic, how did it become doubly important? It's no surprise to any of us that patients didn't want to come back for in-person office visits. While telehealth certainly helped fulfill some of what we needed, the opportunity to do a 28 joint count for somebody with rheumatoid arthritis, for example, became really a lost opportunity as patients either refused or felt unsafe or it was just inadvisable. So the notion that patients' data, either as single data points or even in aggregate, might be an effective surrogate for what you could learn from an in-person joint exam for somebody with rheumatoid arthritis became doubly important.
Yes, and I think that's so true. And I think things obviously hit at different times around the country, but I don't think anyone in the US or probably around the world had situations where there were points where patients really just didn't want to come in and be seen by their doctors. And to some extent, that's still true. So could you speak a little bit about the machine learning component of this research? And I guess the question that I have and kind of breaks my heart a little bit is, can a machine really learn better than a well-trained rheumatologist?
Machines can do some things better than a well-trained rheumatologist or a well-trained physician in any specialty. So they're very good at integrating multiple points of data. And in fact, that was the framework for this analysis. where we were interested not just in a single variable like a patient global score, how are you doing on a 0 to 10 scale, but we were interested in a variety of different patient-reported outcomes. So fatigue and how well you're able to interact socially based on your health, and your physical function, and how much pain are you in, and how much it limits you from doing your day-to-day activities, and how do you sleep, and things that both matter to patients and also health domains that patients can tell us about. So integrating all of those different pieces of information is very difficult for any physician. How do I give you 50 or 100 data points and say, quantify everything that you might learn from dozens, hundreds, or even thousands of patients or more, and then apply it to Mrs. Smith standing in front of you right now, or who is at home filling out this information on a smartphone app. So if the information you need to know is well quantified, and you don't need that indefinable set of skills that physicians in fact excel at, machines are quite good at that task. And that was a great setup for this particular problem that we sought to solve.
And the data that you received from the patients was really questionnaire response data, or it was more kind of a data pulled from smartphones without the patient specifically inputting?
It was data collected from patients, again, mostly patient-reported outcome or PRO data. It happened to be collected at infusion visits. So, for example, the two medications in this study, infliximab and golimumab IV. So these were often visits where you didn't, in fact, see the doctor, but you might just fill out a set of paper or electronic questionnaires during an infusion appointment. That said, the setting should largely be agnostic to the type of data, meaning that you could collect this information from patients through a variety of means. You could do it in the way I just described. You could also collect it on a smartphone. You could collect it over the phone with a computer-assisted telephone interviewer helping get the information from the patient. The point is that it's information that the patient by themselves can give you. You don't need anything from the provider, and you could collect it using a variety of technological means, either in person or at a distance.
And then you plugged into the machine learning algorithm a bunch of things that are also available in the electronic health records. So blood pressure, comorbidities from the problem list, baseline medications, features pertaining to the rheumatoid arthritis, and kind of integrated those variables with the patient-reported outcomes. Are you able, as best you can on a podcast format, give us an overview of how that modeling worked?
Certainly. So the idea was take everything that the physician might know from his or her electronic health record, demographics, comorbidities, medications, and then combine that using the set of algorithms that we adopted with everything that the patient could tell you over time, and then use that to predict or proxy or classify, if you will, what the clinical disease activity index or the CDI would be. So the CDI, of course, would be the most commonly used metric that we would measure in rheumatoid arthritis. It would incorporate the physician joint count. But that, again, is the setup. You don't get a physician joint count. So you might start a new biologic medication, as was done in this trial, and then you'd like to know, well, how are people doing 3 or 6 months later, but you don't get a follow-up CDI. So could you use everything in the EHR or simulated data for what was in the EHR, plus everything the patient was telling you about 6 or so months later to classify or predict the CDI that you don't get to have because the patient won't come back in? That's the setup. So we used a variety of different machine learning algorithms. The one that performed the best happened to be one called Random Forest, but we in fact used several. We randomly split the data into 80% training data and then a 20% test data set. The idea is if you're going to use lots and lots of data to classify or predict, you want to know how well that your model performs in data that wasn't used to train the model. Otherwise, you have this problem of overfitting, meaning your model just looks too good. It fits the data used to train it better than it would fit some other similar data set that wasn't this exact one. So that's this notion of this random split sample. So a majority of the data is used for model training, and then you have this data that the model has never seen, and that's what you evaluate testing on. In fact, in the training, our classification was nearly perfect, meaning the model got it almost exactly right almost every single time.
Mhm.
But again, that's why you have the test data. So we then repeated that 50 different times. Then we used multiple different machine learning algorithms. So the details are in the full paper, but this is a fairly common way to implement machine learning using these separate data sets. The results of this showed that there were a variety of different variables that emerged as important. Again, almost all the variables are derived from patients during follow-up. We did use some of the baseline information, but the positive predictive value, which is the main measure of was this useful, was it helpful, was 84%, meaning when the model said this patient has achieved low disease activity by the CDAI, it was correct 84% of the time, and the overall model accuracy was 80%. The specificity was 93%. And the other machine learning methods were more or less about in line, but random forest outperformed the others a little bit better.
You looked at a few variables that we know kind of impact response. So, for example, prior biologic use. But I think you didn't drill down to kind of look at specific prior medications. Is that correct? So I guess, could you explain why you didn't drill down into prior medication use? And was that just that the data wasn't deep enough to give you rigorous historical information, or what was the rationale for that?
So we did include the number of prior biologics. We didn't include which specific biologics that the patient had been on. In fact, those weren't in the data, but we did include as some of the features or some of the variables that the model could pick from, whether you were biologic naive or whether you had been on exactly 1, 2, or 3 or more. The idea being that the more things you failed, the more likely you are that this next thing, which happened to be an intravenous TNF inhibitor, is more likely not to do well for this patient. So that was included, just not the specific meds somebody had been on in the past.
Yeah. Okay, that makes sense. And a few follow-up questions specifically regarding the data set you used for this analysis. So this data was from a large clinical trial. I wondered, has anyone looked at similar modeling in more real-world environments? So, for example, we all know electronic health record data could come from a single independent clinician or could come from a clinician who's seeing a patient in the setting of a large multi-specialty group where multiple providers in the health system are all inputting data into the EHR. Do you think those things would impact the performance of the model?
Well, I think so. But again, this project was intended to be the setup to use larger real world data sets in the way that you've just described. I do a lot in the digital health space with my scientific collaborators at the nonprofit Global Healthy Living Foundation, or GHLF. They maintain the Creaky Joints patient community and the Arthritis Power Research Registry. So in fact, we have just finished enrollment for a new rheumatoid arthritis patient study where we are giving patients the same kinds of PRO measures to collect on the Arthritis Power smartphone app. And then we're also coupling that with passive biosensor devices that patients are wearing, looking at the hypothesis when somebody's starting a new drug for RA, can both the PROs, like in the analysis we did in this data set, be used in conjunction with passive data like actigraphy that you would wear on your wrist so that we could have both active and passive data from patients between visits. So yes, this setup was very much the intent to be a foundation, but then to be extended into some real world data sets that has the framework I've just described, where you have active and passive data.
Yeah, great. And I guess as an expert in the field, can you give us your thoughts about the role of AI and machine learning in the future of medicine? I guess in particular, do you see MDs potentially being replaced by the other type of MD, the machine doctor?
Well, I don't think so, because it will take physicians and those with informatics and computer science type skill sets to be able to both create algorithms, but as well as to harness them. But I don't expect that we're ever going to replace physicians with any sort of an algorithm. Algorithms are simply tools. They're tools that help integrate data from lots of different sources. But ultimately, I think that the humanistic elements of being a physician, how do you interact with the patient? What are you going to say to him or her? How do you take risk estimation for the likelihood that somebody may have this event happen in the future and translate it into something that makes sense to a patient? So there's the communication element, but then helps with shared decision making because there's not always a right answer. And rheumatology, like most medical specialties, has enough nuance to it that I don't think the computer is going to be making decisions for the vast majority of the scenarios that we encounter. The human element about what is most important to patients, I think, is always going to be front and center. And for that reason, I don't expect that anytime in the near term we're going to replace physicians with an algorithm that simply spits out a number or tells you what to do.
Yeah, and I hope that that's true. I guess to play devil's advocate for a moment, I wonder, whether there is a potential for these technologies to end up harming patients. We've seen in clinical medicine, particularly in the United States, a lot of algorithms being applied by insurance companies to drive decisions on patient care without the insurance obviously ever examining the patient or understanding these kind of matrix nuanced nature of decision making. Can you give us your thoughts on that and whether this data could potentially impact insurance decision making, perhaps restricting access to certain drugs or potentially harming the patients in the long run?
Certainly. I think it's a real concern. I think for a setup like this, where we're predominantly using clinical data, or one might even think of biomarker data used in conjunction, I think that risk is probably low. But like anything, a tool is only as good as or as harmful as the use to which you put it. Unlike genetic testing algorithm, though, where you can't really change your genetics, and if you are high risk for breast cancer, for example, based on your genetics or family history, you can't change those things. But for clinical events, there may be modifiable risk factors, and I wouldn't look at algorithms as a static thing. What we don't know very much is, well, could you modify risk? Could you modify treatment response by doing certain things or optimizing other elements of the patient's care or treatment, if they stopped smoking or if they lost weight or if you used other co-therapies? So I wouldn't look at these as simply static and we can't do anything about them and you're just stuck with whatever the machine tells you is likely to happen in the future. To the extent that some of what goes into these algorithms may be modifiable clinically, I think that helps provide some protection against that kind of misuse. But again, that's another role for physicians, is to use these things prudently in a way that doesn't disadvantage patients.
Yeah. And I was also interested that your algorithm obviously includes some components that are to some extent both social and biological variables, and that could be considered to contribute to a level of unconscious bias in medical care. The obvious examples being demographic variables, age, sex, and race. And obviously, we've had previously issues in the rheumatology field where flaws in clinical trial design and execution have led to therapies being perceived to only work in certain demographic groups. Do you foresee that these algorithms could perpetuate those biases, or do you think there are ways to run the algorithms independent of those variables and potentially perhaps even filter out some of the unconscious biases that humans have in their own brains?
Well, I like this question very much because it again speaks to what is the physician doing, whether right or wrong, that is either adding information that the machine doesn't have, or in fact, perhaps even being misled by information that the machine doesn't have. This is something that physicians are sometimes good at, the idea that this is a sick patient or a frail patient. There are definitions for that, and yet one might say that there is a rather indefinable aspect to patient evaluation, whether that's visual or something more comprehensive, that a physician can do that's just hard to boil down simply to numbers. So in as much as that might be something that the physician could, in theory at least, do better than a machine, it's also subject to the kind of unconscious bias that you just described. To the extent, though, that these algorithms are simply based on data, it doesn't care what you, the doctor, think of your patient. It doesn't care whether you like him or her. It doesn't matter whether they're respectful or treat you well or talk nicely to you or have a certain skin or eye color or hair color or, whether they were late for their appointments. If none of those things matter for whatever it is your algorithm is trying to predict, then you can get away from this notion of unconscious bias. The particular algorithm in this analysis that performed best selected from 53 features or 53 variables, same thing. Age, sex, demographics were not anywhere in the top 15. So I think that it's more likely that this type of automated or empirical data approach could reduce unconscious bias that might creep in, particularly for elements like treatment response, where there may not need to be many intangibles that the physician has to substitute, but that would be hard for a computer to quantify.
Yeah, no. So it actually could help us, it sounds like. So I wanted to shift gears a little bit now and talk a bit about you and your career in medicine. You have an interesting background because you are board certified both in rheumatology and in clinical informatics. Could you tell us a little bit about that and how does one go about getting a clinical informatics certification?
Sure. So this is a somewhat atypical and unusual pathway that has been available for a number of years, but I still encounter many physicians who look at me blankly when I say I'm doubly board certified in rheumatology and informatics. They weren't even aware that that was a thing. So most of us are board certified by the American Board of Internal Medicine as subspecialists, but the American Board of Preventive Medicine, the ABPM, does a number of additional certifications for board eligibility and certification in informatics, addiction medicine, etc. So there's two different mechanisms by which you can do that. One is you do at least a 2-year informatics fellowship. That's one option. That obviously would extend one's training beyond the 2 or 3 years for rheumatology, either concurrent or past that for most physicians. The other option is called the practice pathway, and the ABPM allows somebody who has been working in the informatics field for 3 or more years, or who has a master's or PhD in informatics or something very closely related, like computer science, for example. That is the so-called practice pathway. Essentially, it acknowledges people who have been doing this, who are doing this as a major component of their career, can also be eligible, and that eligibility now is extended through 2025. There's still all the board requirements for certification, exams, maintenance of certification, etc. So it's not much different than we're used to in rheumatology, but allows you to have both.
Do you think that extra certification broadened the opportunity for you to do clinical research, and how and why?
Well, very much so, because my background is in real world evidence or pharmacoepidemiology. But as time went on, and I still do a great deal in both of those things, it became increasingly apparent that for us to be able to improve care and to be able to scale important advances in medicine with the help of technology, informatics was going to be quite essential. My background is actually in computer science in college and as an undergrad, and then for a few years before I went to medical school, I was a computer programmer and a systems analyst. But that was back in the time when informatics was really people who were excited about computers as a tool for their own sake. It was only once they started to have tools in the informatics world be useful for patient care and for clinical use that my interest was reinvigorated. And so for that reason, now that we do have tools that can become practical to help doctors take care of patients and to improve quality, I think informatics is really essential to be able to have for people on a team that is trying to improve the health of not just one patient in front of you, but for a whole clinic or a population of patients.
Yeah, and I think as informatics have just become in the last 20, 30 years kind of integral to what we do in medicine, it's become essential. As we all kind of realize that we're about to be replaced by machines, I am wondering, specific to you, were there pivot points in your career where you consciously decided to change direction? So this change from computer science to medicine and then to the clinical informatics field. And as you made those pivots, what algorithms did you use to decide how to focus your time and efforts?
Well, I'm not even certain that I would call it a pivot as simply a broadening or an expansion. From interests in clinical medicine and then adding epidemiology and pharmacoepidemiology and real world evidence, how do the medicines and other treatments that we use help or harm patients? To me, that was sort of a logical extension of research. And then if you're building tools or you're trying to create systems to collect data, to build clinical decision support to help patients, my main focus of my time is really what can we do that can touch the lives of patients in a positive way? How can we give doctors the ability to provide good patient care? And something particularly unique in rheumatology is we have a workforce shortage. And while we have many disciplines of medicine that have workforce shortages, I think ours may be particularly bad in rheumatology. There's a lot of interest, including at the ACR Convergence meeting, on trying to help overcome the workforce shortage, but it's mostly on the supply side, meaning train more doctors. My interest, however, is not just that, but also how can we make care more efficient? How can we bring tools to the digital health space to enable doctors to provide more efficient care to patients? I think the days of saying, follow up 3 months routinely just because you need lab work because, may eventually go the way of the dinosaur, simply because there aren't enough of us seeing patients to have that luxury. And that's where digital health tools like machine learning algorithms could take great advantage of, can help us be more efficient as a field. The last thing that I think I would mention is in January of 2022, so just over a year ago, the idea that one might use a smartphone app with one's patient to take care of them has left the research-only space and has now become reimbursable by insurance, meaning that rheumatologists who would invite their patients to use a smartphone app to collect the kinds of PRO data that were analyzed in this study using something in their pocket or in their purse, that now is compensable by insurance simply for clinical care. So a lot of the work and interest I've had in digital health just has entered mainstream a year ago, that insurance now pays for this. And to me, that gives us tremendous opportunities as rheumatologists to take better care of patients 365 days a year, not just the 4, 5, 6 times a year that they come see you in the office.
That's actually very interesting. I think our audience are going to be quite interested by that. Can you give us a bit more specifics? How, and is it a modifier people add, and how does it work?
Sure. So there are 4 new CPT codes. So CPT are the HCPCS codes. Those are, of course, the billing codes that physicians and medical providers use that were introduced 13 months ago in January of 2022 that makes both the technology as well as the time of staff people in a physician's back office to review digital data streams reimbursable by insurance. Roughly, the Center for Medicare and Medicaid Services allows physicians to receive compensation of about $100 per patient per month to use smartphone apps and digital tools, including collecting the kind of data that we analyzed in this study. Roughly half of that $100 or so pays for the technology, so that's what helps tech be self-sustaining. The other half is compensating the provider's back office staff to look at these digital data streams, to review dashboards, to perhaps even to use, machine learning algorithms run on that patient data to help provide care. Basically, the office staff is providing the same kind of care that they were before. This is just a way to enhance it with both a digital data stream, but then also make this insurance reimbursable. And at a minimum, I think a lot of rheumatologists are going to welcome that new ancillary source of revenue, plus be benefited by having more and additional data on their patients in a way that doesn't burden them and doesn't add a whole lot of time. And none of this is necessarily requiring direct intervention by the physician. This is mostly their office staff that's taking care of patients' data as these data streams are coming in. This isn't all time billed by the physician, because if it was that, this kind of a program would be dead before it started. This time is being billed incident to by the office staff working under the supervision of the provider.
Yeah, very interesting. I feel like that could be an entire discussion on its own. And I'm sure that is the kind of future of medicine that we're looking at. And so I'm kind of fascinated to see how this evolves. I want to thank you, Jeff, for coming on the show today. That was a fascinating discussion. I sincerely hope that you don't analyze this podcast with machine learning, but if you do, I hope that you rewrite it in the format of a Taylor Swift song. Thank you so much for joining us today. It's been a pleasure having you on the show. I want to close in this episode by thanking clinical informaticists around the world. The field is young and evolving. And I know that some listeners won't believe this, but there was a time in the not too distant past when we used to use handwritten clinical notes and fill out lab slips by hand. I think we all appreciate how much technology has transformed the field of medicine. And I do hope that part of the physician's role is still being able to translate that medical care as a partner with their patient. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRoom on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.